The Bay Area Association of Kidney Patients presents a panel discussion on kidney transplantation featuring distinguished medical professionals who work day-to-day with kidney patients. All three of them are from California Pacific Medical Center. Vicki Martin is a pre-transplant nurse coordinator covering the South Bay. Betsy Buchter is an outreach nurse transplant coordinator for the South Bay. And Pamela Rock is a social worker.
So one of the, I think, the major questions that most people are afraid of is the financial aspect of transplantation and being available for after transplantation. So one of the panels want to address the financial aspect of that.
Wow, that's a big question. First off the bat. Well, you know, as a social worker, one of the first things that we deal with patients is talking about insurance. And sometimes it's kind of a hard topic to talk about because you're more concerned about getting a transplant and about, you know, having a better treatment for your kidney failure. So when we first meet with patients at eval, we start talking about insurance. We start educating patients about Medicare and about different insurances that help them through the surgery, which is the first half, but then for those of you that have a transplant, you know how important those medications are and how they're very expensive. And insurance becomes really like a lifeline to the medications after transplant. So does anyone have any specific questions about insurance? I can try to answer them.
Does Medi-Cal pay for transplant?
Medi-Cal does pay for transplant.
And the medications afterward?
And the medications afterward.
Thank you.
Yes.
I'm with Kaiser, which is an HMO.
Okay.
So does that mean I can't go to your organization?
True. We aren't able to take Kaiser insurance at our particular hospital. So you could talk to maybe your social worker and find out if there are other options available to you. Yes.
My name is Barbara Elliott, and I'm a transplant patient. My 6-month date will come up on the 19th of this month, and Dr. Katz-Nelson was one of the transplant team. I've had excellent care from all CPMC. But one of the things that did surprise me in trying to get insurance, once you state you've got end-stage renal disease, they don't want to know you. Just before I've been on the waiting, was on the waiting list for 6 years, and AARP, with a number of years, well since I was 50, they dropped the program. So it's very hard, and at the moment, I talked to Pamela about this a couple of weeks ago, the medications are expensive. My monthly Blue Shield, which is a PPO, which covers the medications, I have to pay $854 a month for, plus the $100. And I just recently went to Walgreens website, and I spent over $1,000 last year in Walgreens alone. So they are expensive, and I'm now going through I'm on Social Security. I have a small pension from uni, and I'm now going through all my expenses, and I'm considering I've got to go back to work again to pay for my medications. And I do have other options, but they're drastic. But just to let you know, they really, really are expensive, and they do hit you in the face. I mean, you're told they're expensive, but you're not told how expensive they are. If you don't have insurance, the out-of-pocket for one of the immune suppressive is over $1,000 a month.
Right, that's just one of them too, and there's other ones along with that. So.
For those of you in the back, the question that she had mentioned, or she was stating that the price of medication is very expensive, and there's many options that are available through local pharmacies and organizations, but I don't know if those organizations are available to pay for those. So she just want to let everybody know that medications after transplantation is very expensive.
And it's also hard to get insurance unless you pay a big
Insurance
premium.
is a very hard thing to get to attain.
May I build on that, please? I'm also a post-transplant patient like Barbara from CPMC, and after transplant my meds cost, well, it's currently $3,000 per fill, which is a 90-day fill. However, they're a lot less than they used to be. And I ended up having to apply to the pharma company's patient assistance programs directly, which is kind of a long, involved process of organizing your paperwork. But I was able to get immunosuppressant support from 2 different pharmas last year. However, now, because my financial circumstances changed a little bit, I no longer, my asset limit is too high to get one of the 2 life support meds I'm on. So I have discovered yet another foundation. I was able to get a $2,000 grant through this organization. It's called Healthwell Foundation, in case any of you need to apply, which will help cover the Medicare donut hole, the coverage gap. But this, this is going to be a lifelong challenge, and I'm always eager to hear what other people come up with to help with that. Because what Barbara said is correct. Once you have end-stage renal failure, you're no longer ever eligible to get insurance as an individual. If you're an entrepreneur or you're someone who's worked for themselves. As a group, that's different. There might be some exclusions if you're going back to work for a company or a corporation, but as an individual, that's it. You're out. So we need to build more solutions for this problem, especially in that you're going to be on these meds for the rest of your life, and they're going to, even if they make generic equivalents, as in the case of the program, there will be a generic equivalent. It's not on the market yet.
Can I just add a comment before, because it's a slightly different perspective before you pick up, but I also had a transplant at CPMC in April last year, so the 3-way transplant that Dr. Katz-Nelson referred to.
Yes.
Now I'm covered by Blue Shield as you are, and I think my monthly premiums are similar, but I got on Medicare about a month before my transplant. So my transplant was April 27th, I was on Medicare April 1st, and I have to say, since then my monthly meds are between $160 and $180 because everything's pretty much picked up by Medicare. I still keep my Blue Shield for expenses that aren't, picked up by them. But
was it a Medicare supplement Blue Shield, or did you obtain the Blue Shield prior to your transplant?
I had the Blue Shield prior, but when I applied for Blue Shield, I simply had to say, do you have a pre-existing medical condition? And I checked the box because I have polycystic kidney disease.
Yes.
And that was the end of it. So
that's good. I'm also a PKD patient, and I had insurance through a corporation that I worked for, but when I became disabled, I went into COBRA status, and after that was no longer eligible for conversion from the insurance company. Fortunately, I was able to get Medicare to cover that, and now I have Medicare and Medicare supplement and a Medicare RX plan, as long as I'm still deemed disabled. However, if I go back into the workforce as an individual, we cannot get insurance.
So I have a question. How many of you here are thinking about getting a transplant? Are there a lot of people who are thinking about it? So I can kind of go over briefly what insurances are common and how they work for transplants. And we had one question already, does Medi-Cal cover transplant? And the answer is yes. Another insurance that a lot of patients have going into transplant or dialysis is Medicare. And so Medicare and Medi-Cal together is something that we see a lot for transplant. And one of the reasons that patients have both of these insurances is because Medicare doesn't cover all the costs. So it seems like no matter what insurance you have, unless you're working, there's always going to be some out-of-pocket costs. So a lot of patients have more than one insurance. So when you start on dialysis or when you have your transplant, whichever comes first, you can medically qualify for Medicare. Now that doesn't, automatically get you Medicare. You also have to have enough work credits with Social Security. Now if you think about it, we all get this statement that comes in the mail every year that talks about how many credits you have with Social Security and your work history and all that. And that'll tell you if you have enough work credits to qualify for Medicare. And so coming into transplant, a lot of patients have Medi-Cal and Medicare, and that covers pretty well. That gives you have some small out-of-pocket co-pays for prescriptions, but all your your doctor's visits and your labs and all that are covered pretty well. And the same goes for Medi-Cal alone. If you don't qualify for Medicare, you may qualify for Medi-Cal, and then that would cover you for transplant. But one thing that, I said before that there's the surgery part and then there's the medication part for after transplant. So after transplant, there's some crazy things that happen, and one of them is that if you're of working age, Medicare will only cover you for 3 years, and then it'll terminate. And I have patients call me all the time, like, oh my gosh, I'm so worried because I don't know what I'm going to do. And it's kind of piecemealing things together, like, some people who are fortunate enough to be able to go back to work and get on some good employer group health plans, those are great. And so we're really trying to find ways to support our patients to go back to work because that's their best option. But if that's not the case, that's where it gets kind of confusing because there's so many different options and everybody's case is different. So let's see. What questions do we have?
Excuse me.
Yes.
Let me throw out a suggestion here for these sessions, because this is obviously a really worrisome issue, and I've heard lots of conflicting information about what you can and can't get, and to some extent there is a confusion between available and affordable, which admittedly sometimes the distinction's not real clear to a lot of people. But one of the things that might be useful is to have an employee benefits broker come and speak to this group. And there are plenty of them that do small businesses and individual plans as part of their service. They do financial planning and insurance brokerage. And they would be the people who would be the most familiar with what legally you have a right to have and what you don't. And I know that, for example, HIPAA has some requirements about what kind of insurance companies are required to offer people who can't get insurance any other way. And I don't know how affordable those alternatives are, but I know there are alternatives available, and a benefits broker might help a lot and clear up some confusion.
That's something we had talked about having, is the whole question of insurance.
Well, it's a huge issue for everybody, and it's really complicated, unfortunately. So.
And there's also an agency called HICAP, the Health Insurance Counseling and Advocacy Program, that knows a lot of the regulations and resources for people who have Medicare, both for seniors and for people who are disabled. So that's another really good resource that we use to help people with questions. It's called HICAP,
Okay.
the Health Insurance Counseling and Advocacy Program, HICAP. But that's a resource. I mean, for most people, we are able to find a way to do it, but at the same time, it's important to understand that it's not automatic and it's not all laid out for you. You really have to kind of get involved with it and kind of understand how the Medicare stuff works.
If I can just inject, there's 2 other resources. One is a Mr. Mitt, and it is expensive. You do need to be receive a decline in obtaining insurance, a letter indicating that. And for approximately $700 plus you can have this insurance. However, remember, if you're paying $1,000 plus a month, that may be helpful to you temporarily until other resources come up, as opposed to having to foot the whole bill each month. The other is American Kidney Foundation does have a program to help you fundraise. If we're going to buy a house or something, we're always planning ahead for that. Well, this is keeping our life going and planning ahead. And they will give you information on how to do fundraising, how to set up individuals to do it for you so you're not involved in it directly. I mean, there can be golf tournaments or bake sales or whatever, and she's got the brochure right there. But it goes into a tax-deferred account specifically geared to help you medically with your medications, doctors, whatever it is that's related to your condition.
Isn't it a shame though that we have to resort to that kind of thing? I mean, the whole house, well, is another issue.
It is, but it's called survival,
yes,
and there are ways to getting around it. Unfortunately, they can always find a way to get you transplanted, but it's up to you to think about how am I going to go on. And there are resources there, there really are. But it is a tough road.
And
no
I'd like to
question.
interject that we are pretty thorough, or there's social workers and financial counselors really reviewing with you before we accept you to receive a transplant, because we want you to be able to take care of it and not put you in a situation where you're strapped. So if it's looking like a hardship, we'll be presenting that to you. Is this something you can afford and whatever, and then providing other options to look into.
So if you don't have the financial resources, are you turned down for a kidney transplantation?
Well, if we feel that you won't be able to access health care and get your medications and take care of yourself, then it may delay your transplant until we can figure out a plan for you that's going to work. Now, Victoria mentioned a couple of the fundraising agencies, and that's something that is available for transplant patients. There's a lot of patients who feel they have so many out-of-pocket costs that they just can't make ends meet. And so there's at least 2 fundraising agencies that help out. So I have 2 brochures only today, but I also have my business cards, and you can feel free to call me and I can send you some information or give you some additional information on that.
Maybe, Pamela, maybe if you could introduce a little bit about your role, because a lot
So
of the social workers'
a lot of the
role,
questions that I've just answered are kind of the financial person's role.
And she could not come
Talking
today.
about
She's
coverage
actually
and
working
things like that.
to get some patients who were called in insurance coverage for a transplant and forward, so that's why she was not here today.
So as a social worker, I guess what I see is my primary goal is to help empower my patients so that they can handle these types of difficulties that might come up with transplant. I think it's one of the most challenging things for patients is to go from an independent role out in the workforce to a dependent role on dialysis, and then have to transition back into a more independent role after transplant. So that's a lot of, it's going back and forth a lot. So I think we take a real focus of empowering patients at our center and try to arm you with information about insurance, about support groups. We're trying to get some of those to work, and this is a wonderful group. I'm so happy to be here today. Let's see. When we first meet patients, we start off with education. We have a slideshow that kind of explains how the psychosocial parts of transplant work. Then we sit down with the patient and do a face-to-face psychosocial evaluation and talk about strengths and areas where we can, hopefully improve situations, and one of them is insurance. So we start right from the beginning working on that. We're also looking for support system, how someone copes with the changes that they've had in their life and what their supports are. And we also screen for depression, anxiety, those types of things. We're trying to screen for other things like substance abuse problems. I mean, sometimes people don't have real good coping skills, so we need to deal with those things before we can move on to transplant. And then, let's see. Another part of the social worker's role is to talk to living donors. So, kind of similar to the kidney transplant recipient evaluation, we also talk to donors and try to prepare them for what they're going to be going through, and be sure that they can handle it and that they're well prepared, that they're not being forced into donating, that it's not going to cause any negative effects in their life, like cause bankruptcy or things like that. So we get very involved in that type of thing and really try to give resources for planning so it's a smoother process. Let's see. Now, as far as disability for transplant, when patients are working and then they're going to have a transplant, there's something called state disability, and that can help you with some of your lost wages during the time of your transplant. And usually patients take about 3 months off from their job, at least at our center, just to heal from surgery, to get used to the medications, Sometimes it takes a little while to get back on your feet and feel back to normal. But usually patients do definitely feel more energetic and are so grateful enough not to be going to dialysis treatments after transplant. So that's really helpful. Let's see. Now, if you're on Social Security disability or you're receiving SSI or Social Security disability, those programs usually follow you for at least a year after transplant. But if you're of working age, if you're in your 30s or maybe your 40s, maybe 50s, I'm not sure, they may review your case after a year or so and just kind of see how you're doing. So if your kidney failure is the only thing that was kind of holding you back, then they may want you to go back to work. So unless you have some other problems medically, your disability should last at least a year, maybe 1 to 3 years, just kind of depending on how you're doing. Let's see. There's a question here about alcohol, drinking alcohol after transplant. Now, alcohol is something that doesn't really damage your kidneys in reasonable amounts. So there's really no requirement that we have that you have to stop drinking everything before transplant or after. But again, you need to be really careful that you're not kind of getting over into abuse or you're not dependent on alcohol or other drugs as well. I think it's really important just to take a really good holistic approach to your health care and just really be aware of what's going on and involved. I feel like I'm going on and on. Are there any specific questions that anybody would like to ask before we move on? Yes, ma'am.
Do most of the time the drugs that we have to take after transplant, do they work? And if they don't work, do they have different drugs that they can try? Or they just have certain ones?
There are some main drugs. So basically what we're using them for after transplant is protecting that kidney from your own body and rejecting it. And the one thing to keep in mind with transplant is rejection is a normal process of transplant. It just means that your body has recognized this kidney does not belong to you. Right after transplant, when the doses are the highest, you're on some extra medications to prevent you from acquiring other infections. After that 3 months, some of those medications will drop off. But the main medications, you'll stay on those as long as the kidney is working. There are different therapies over time. I mean, back when they used, there's some people I'm sure that are still on just prednisone and Imuran. But as new drugs come out and they become more effective, you know, there are other drugs to choose from. But it's one of those, if something's working for you, you usually are going to stay on it. But yeah, we have some other options out there, but usually there's a main regimen of drugs that you will be on.
How many different medications do people have to take? And does it differ with each person?
It can differ with every person. I don't know if you'd see our picture. It's a lot. You know, when the social worker asks in our evaluation, why you want to transplant. One of the things you don't like to take pills, transplant might not be a good option for you. There are a lot of pills. There are a lot of pills.
Here's a picture here in case you want to come up and look at it. It's like a little handful.
We could pass it
A
around.
couple times a day.
Pam, is there like a class that they'll have for you prior to transplantation?
Yes, usually when you go for an evaluation, I'm speaking for just in general here, the center will have a class and they'll talk about what's going to happen during the surgery, at least at our center. You know, what's going to happen afterward, what the medication's like, what the surgery is going to be like. Just trying to give you an idea of, you know, kind of what am I getting myself into kind of thing. Because, you know, patients are really anxious when they come to see us. So we're really trying to give them information to help them calm down and just take one step at a time through this long process. But it's really important to think about taking that first step, because if you don't do that and there's this long waiting list, it's going to be, you know, longer and longer for you. So
I think maybe a good way for us to present it at this point is sort of how the process happens. You might have seen Betsy, she's one of our outreach coordinator. We all work together as a team. you know, Betsy, what don't you tell me to do?
I'm the nurse outreach coordinator for the South Bay area for CPMC. So in my job is to help when there's people that are new to dialysis that have questions. The social workers, sometimes the patients or their families will call me and say, help, what do I do? I want to get on the list, but they are not sure exactly what to do and how to go about doing that. So for the patients that are already on dialysis, I'll come out to the unit and explain the evaluation process, the transplant process, and answer their questions and get them set up with an evaluation. And during that evaluation, that's when we have the class that Pamela mentioned. So we cover all these topics. We cover everything from who can be a candidate to the surgery, what the medications, what the side effects might be like for them afterwards. And then they see the doctor. So for example, Dr. Katz-Nelson might come out that day for, we travel to different sites around Northern California. So in my clinic, which is San Jose, Dr. Katz-Nelson might come out. So after the class, you would see him for about 20 minutes to half an hour to evaluate your whole medical history. He'll do a brief physical and help you look at the risks and benefits of transplant and help you to figure out, is this going to be the best thing for me? And then you'll also meet individually with the social worker if it's Pamela for that day. And then that's when we also draw labs for to find out your blood type and to find out ultimately who's going to be the best match.
I think sometimes what happens too, people aren't really sure they want a transplant, but often we'll encourage people, you know, if you think you might want one, let's get you on the list anyway. Let's let you gain some waiting time and you'll be in what's called inactive status. We're not going to offer you a kidney, but you can start gaining time until you find out more information so you can ask more questions, speak to people who've had transplants. Is this something I want to do? You know, so in that way it's in your best interest because blood type O's, they're waiting 5 to 7 years. So if you start now and just say, gee, I don't know, I want to, you know, see if you can get your name on the list just to start gaining some time. And
is that list prioritized?
Is the list prioritized?
How do you, you're on this list.
Mm-hmm.
Who's to say when, is there a number? Sure say, or you've been on there 6 years, you go top.
So what happens when Betsy sees
after we do the evaluation?
Yeah, she gets blood work drawn. The social worker evaluates their recommendations. The physician has his recommendations, gives the patient a list of tests. Gee, and they'll tell you right off, we think that you're probably a good candidate, but we want to get more medical information from you and really see what your current medical status is. Okay, all that information comes to me. I'm what's called a pre-transplant coordinator. So I'm up in San Francisco. When the blood testing comes back, I find out the blood type. And actually, if the doctor and the social worker recommend they're probably going to be a good candidate, I place the person on the wait list, send out a letter confirming you are on the wait list as of this date. And then give the whole list of tests. Gee, we want you to get these done. Let me know when you've got them done. When the doctor's reviewed them, the social worker has signed off that everything's okay from her perspective, then you're eligible to get a kidney. Well, a lot of things would happen at that time. People get this letter and they say, oh my God, 5 to 7 years, I'm not going to get these tests done now. Why? And they basically put it off. Well, what happens is at that time you go on a local wait list and also the national wait list, which is called UNOS. And I think Dr. Katz-Nelson mentioned that identical matched kidneys have a highest success rate, right? So what happens is even though most of our kidneys come from our region, whenever there's a kidney donor anywhere in this country, the tissue typing is put into a computer. And anyone that matches that kidney identically gets first offer. So if you were listed today, an identical match comes up tomorrow, that kidney goes to you. So what if you're ready? Yeah. And so that's why I encourage anybody who's on the list, get your test done. Call us up. A lot of people say, oh, gee, I never hear from my coordinator. Well, there's 3 other coordinators like myself. We all follow about 500 patients. So luckily, like I said, Mr. Barron, I spoke to him a lot, never had met him, but he was one of those squeaky wheels that kept calling me. which is what I encourage. We want to hear from patients. We want, if you just have questions, you're not wasting our time. We love to talk to you. And a lot of times when you do tests, you just assume that, gee, yeah, my doctor's sending those in. And maybe they did. Maybe the fax machine wasn't working or whatever. Confirm that with your coordinator. Each region, you know, I work with Betsy in the South Bay, but there's another coordinator that works in Modesto, one in Fresno. Find out who your coordinator is, call them, say, gee, what do I need to do to be active on the list? I know I'm on the list, but could I get a kidney tomorrow? So, you know, do your part, and we're glad to do whatever we can to work with you.
I'm on the UC Med San Francisco list. Do I need to add my name in another list, like at Stanford?
You know, it used to be at one time in the region you could have your name on all these lists, but in one region, and our region is our center, California Pacific Medical Center, Stanford, and UCSF, you can only be on one of those lists, okay?
And all of the patient names in our region are mixed up, so the list, and this might also answer the rest of your question about prioritizing, it goes strictly by waiting time. And so say we're all on the regional list, but I'm CPMC, she's another center, it doesn't matter center-wise on the regional list, it goes strictly by waiting date in a particular blood type. So the next kidney that becomes available in our area goes to the person with the next of the same blood type with the oldest waiting date.
Sometimes people will, like at a unit, they'll say, oh gee, a couple of people got transplanted at PMC, I'm going to go on their list. But it does not matter. It depends on what your wait time is, whether you're listed. So let's say you transfer from UC over to us, you're not going to get a kidney any sooner with us than you are with them because we're all in the same region. And so in terms of picking a center, what I tell people, it's like picking a doctor or anything else. Pick a center that's most comfortable for you, whether it's geographical location, if you feel more comfortable with the staff, or you know, whatever it is. Find some place that you feel that you can relate to the people and feel comfortable. And we do have people that go from center to center, but
How about centers outside the region?
oh, so yes, you can be on others. You could be on another list outside the region. I've had people go up to Oregon because they know the wait time's less there to get on that list. Now, the problems with that too, that transplant center might have prerequisites, like you need to stay within that area for 6 months. Make sure, if you're going to do that, I would talk to your nephrologist here. Make sure you have a physician that's going to treat you when you come back, because putting the kidney in is only the first part. You need someone to really manage those medications and to follow you closely to prevent rejection and losing that kidney.
Okay. I'd also like to add to that, there are a number of patients who are listed at other centers in California that are out of our region. So the centers in Sacramento are considered a different region. So UC Davis, for example, is a center that many patients from this area commonly go and get listed there. And then also some of the patients from this area also will go down to Southern California and get on one of their lists. Does it increase your odds of getting a transplant any sooner? No one's ever been able to answer that for me. In theory, it seems like it would help. The more lists you're on, the more chances you have for other kidneys.
I think the most important thing is make sure you're active on the list. So make sure all your tests are completed, the doctor or social worker have signed off, and that, yeah, if a kidney comes up, I'm available to receive it. Okay, that's going to be number one. And then with other people, there's what Dr. Castellson referred to, the extended criteria donor list. These are older kidneys that are matched to comparable age patients. It used to be donor, there was a cutoff at 50 for cadaver donors, and then people looked across the country and said, gee, there's a lot of kidneys, you know, not being used that might help people. When I think that I'm 50, that, yeah,
there was a question in the back. Somebody had a question in the back.
Oh, my question was, after the transplant, do you, like if I'm registered with San Francisco, will my nephrologist then be somebody associated there? Or will I keep the same nephrologist?
You should keep your same nephrologist. We'll start off by doing a bulk of the care immediately post-operatively. and then reports will be sent with your physician. So we're sort of working together. We still want you to see your physician. He does the bulk of your care. As time goes on, he'll be doing more and we'll do a little less, but you know, we'll be the one essentially managing the care of the transplant for the most part.
For how long?
I can address that. It's different with the different areas and the different nephrologists. There are some nephrologists that prefer that we handle most of the transplant care and most of your medical care. And then there are some who are much more involved and they have maybe a little bit of transplant experience in their background and are more comfortable taking that on a little bit sooner. I think the general rule of standard is about 6 months, but it usually ends up being a relationship that's worked out between our doctors and your like Dr. Gottheiner has many patients in this area, for example.
There's a question.
With regards to signing up with another region, the pre-workup, would your insurance cover that, or does that come out of pocket, especially if you have Medicare and Medi-Cal?
I think usually they do allow, insurances do allow a second opinion.
A second opinion.
And a lot of the workup can be shared. So
and I
we
get
try to
calls
share as much
like
as
that all the time. Can you send my information down to St. Vincent's? I'd like to be on that list. And we're glad to do that. Because, I mean, keep in mind, all centers, our goal is to help the person get a transplant. So whatever we can do to help expedite that, you know, is great. Like I said, I think Mr. Barron called, what do you know about Johns Hopkins? You know, and we were talking back and forth before he was ever even on our list. In fact, I was surprised when you were getting the transplant, because I was like, wow, I remember that name.
So I was on 3 lists. I was on Hopkins and then UC Davis and then UCSF and then your list too, eventually.
Yeah, Victoria, I did see once upon a time where there was a patient whose Blue Cross policy would not pay for an evaluation at another center. They said, well, she's already on the list, we're not going to pay for another evaluation. So in her situation, she was not financially able to come up with the money to get listed in another center. Some patients are, and they're willing to pay out of pocket for different evaluations. But most times, the additional evaluations will be paid for by the insurance.
Question in the back.
If we were already on the transplant at UCSF and would like to transfer to your center, would you be able to use the eval lab works from UCSF? Then, or do we have to do another pre-eval?
Many of the tests we can use their information. I would have to ask Dr. Katz-Nelson about the actual tissue typing information, because we have a brand new lab that has a DNA based on really fancy equipment that tests a lot of very specific antibodies, and I'm not familiar with what UCSF lab does. So worst case scenario, we may need to draw a few extra tubes just to get the tissue typing, but for the other labs, I'm sure we can use their reports.
Is there any other requirement for us to go from UCSF to you guys, paperwork-wise, or we just go to?
There's, you'd need to go through an evaluation with us, and then there's also, if you wanted, you know, after the evaluation, if you wanted to transfer your wait time, there's a specific UNOS form that you fill out and sign that says that you request to transfer your waiting time from that center to our center.
So we will not be starting from again.
And if you move somewhere, like if you moved anywhere in the country or to Hawaii, for example, and you want to take their waiting time, you just sign that form and it transfers your initial waiting date to that other center.
Where will we get those forms?
We have those at the evaluations.
Thank you.
But if I'm listed currently somewhere and I decide I want to do a second listing, say at UC Davis, does that go back to my original evaluation date of being on the wait list?
No. If you have subsequent evaluations at additional centers, then the waiting date starts after you have that evaluation. But then if ultimately something comes up there and you want more waiting time, then you can transfer your initial time to that secondary center. Does that make sense?
So maybe let's say you could apply to a center that the wait is only 2 years. and you're already PMC, you've got 4 years, but you know you got another 3 to go.
Right.
You can switch all that time from PMC to that center, and then start at PMC at 0 again.
Oh, okay.
So put it wherever, you know, to your...
So your total wait list years is 0 sum. If you're on a bunch of wait lists, it's like, you know, miles, transferring frequent flyer miles from one airline to another.
Pretty much, yeah.
But you know, the one thing that Betsy and
I'm here to help.
Betsy and I make a good team, because sometimes what happens in this area, I also take donor call-up night and placing organs with the surgeon. And if for some reason we have an organ that needs to get placed, and let's say the recipient that we originally chose fell through, we're going to want to place that organ. So sometimes it happens, you know, we'll call and say, hey, do you have somebody local that's active, that's ready to go?
They can get to the hospital quickly.
That can get here, and we'll go down the list. So I always say this area is the best. We've been lucky in this area to have a lot of identical match offers. You know, when people want to know, well, gee, what's my chance of getting that? It's usually, they say 6%, but I can tell you there's about 130 we pass up on every year. We opened a new center in San Luis Obispo. I think there was at least 2 that got identical matches within, you know, a few months of listing. And so people want to know what happens when you're going to get a kidney call. It's somebody like me, usually in the middle of the night. And the reason it's in the middle of the night is we find all this stuff out. I think Dr. Kasnelson told you. When they take the donors to surgery, they don't like to disrupt their normal OR schedule, so it ends up some odd time. And I'll just call up and say, hi, this is Vicki from the transplant service. We have a kidney for you. And most people are shocked that I'm going to be calling. So when you want to know what can you do in the meantime, have a transportation plan in place. Know what you're going to do with the dog, who you're going to call, who's going to drive you.
Gas in the car.
Yeah. The directions in the glove compartment. I am glad to walk you through down here all the way to the front door, but it really uses a lot of time. If you know how to get here, it saves me a lot of time in getting the next person.
Right.
So,
also, we brought, and they're over on the table,
Yeah, we have some planners
transplant
that
planners
kind of outline
that outline how
what
to
happens
get
when you get
ready
the call.
for when you do get the call.
And you can have a map.
Question on how does race play in matching? I've been told that if I go to China or Hong Kong, I can get a better match.
well, I think it's what, you know, in the beginning years of transplant, we used to think, gee, if you have 3 out of 6, that's good. But it's like what he said, what we found out, unless you're an identical match, you're going to be, if you have 0 antibodies, things in your blood system that are going to fight against a kidney, you're going to be compatible with a lot of donors, even ethnic-wise. Now, one of the things what I caution everyone on dialysis, we form antibodies in our blood system that fight against transplant. We form these antibodies in a few different ways. One is getting blood transfusions. If you can avoid blood transfusions, that's great. And how you do that, whether you're on Epigen or Procrit, remember the kidney makes renin that stimulates your bone marrow to produce new red blood cells. When your kidneys don't work, you become progressively more anemic. The early days of dialysis, people were always tired and getting repetitive transfusions. Today, overall, people feel a little bit better because of this, and their blood count is up. So that might be one of the things, along with your phosphorus and potassium, see what your blood count is. I'm sure your doctor's looking that over, but I'm one of those. I want to know all my numbers too. Another one is pregnancies and then other transplants. These are ways you form antibodies. I guess in terms of identical matches, it makes sense that if you're with a group of people that same cultural background, you know, but I can tell you we transplant every ethnic group I know.
Can I speak to that for a second? Because something I came to learn, you know, the sensitive subject of race. Well, during Dr. Katznelson's presentation, my brother was up there, and his donor is an African-American female, Creon, and my brother is Caucasian guy from Russian background, heritage, at least part. Those are not the factors that can make you a match. My donor is from a completely different ethnicity than I am. So it's just, you can just throw away all those stereotypes because
Right,
they
and
don't have to
also
be the same.
for the three-way paired exchange that we did, one of the couples was African American, another couple was Korean, and then the third pair is Patrick and his wife is Japanese. Tomomi's Japanese, and we found the best matches outside of their particular race. So yes, in theory, it kind of makes sense that you would
it does
be more
back
likely.
when we didn't have the drugs that have improved, you know.
But ultimately, they found the best matches in someone who is a completely different race.
And also, like Dr. Katz-Nelson was saying, there's a lot of other factors that may be as or more important than the actual match, like the short time that the kidney is out of the body.
And let me just add to Betsy's comment. My wife is Japanese, and she could be a donor to many people. She is generally in good health and without too much complications. But there was an African American woman in the Baltimore area that was virtually impossible to match. And it turned out, just with these matching programs, my wife, who's Japanese, turned out to be the best match. It was virtually impossible to find a match for that lady, and that's why it took place flying across the country. So I think what they say is true, that there's other factors that play in there that are much more significant.
Thank you.
Can we talk about recovery time for the donor as well as the recipient?
Sure. Let's see, for the donor. Now that most of our donor nephrectomies are done under laparoscopy, the recovery time is amazing. When I first dealt with donors, we were doing the open nephrectomy, which is a huge incision in the back. I felt horrible for those people because they were like hobbling around and it took long recovery time. Now it's done under laparoscopy. A couple little what they call stab wounds, a little bikini scar like you would see in a C-section. They are in the hospital 2 to 3 days. We tell everybody no heavy lifting for 6 weeks, no more than 10 pounds, the big thing is sugar. That's because even though they're going to feel great, there's a lot of healing going on inside. What I tell people, I don't care how good you're feeling, 6 weeks, you need to take it easy. Go to the mall, go to the movies, whatever, but no heavy physical exercise. I had one lady, after 1 week, she was off to Mexico with her boyfriend, and I said, you know, you just really need to relax. Well, at 6 weeks, she came back, I am so tired. And what it is, I mean, her body's telling her, you know, you need to have time to recuperate, to heal. So with the laparoscopy, it's amazing to me that you could take somebody's kidney out and then they're just feeling great. Yes?
My wife was my donor, and we were pretty sedentary before the transplant. And 6 months after the transplant, we took up hiking. So,
oh, wow.
Yeah, I mean, the recovery, she did have the laparoscopy procedure.
Well, you know what I can tell you about the donors? They're usually healthy people to begin with, but they are so just I'm going to do what I can do to stay in good health. At our program, what we've started doing, if the donor would we'd like them to come back at least yearly so we can see how they're doing, check their blood pressure, check their weight, and just touch base with them overall and see how they're doing. Now the recipient, they're in the hospital 5 to 7 days, more because we need that time to adjust the medications. Now the first 24 hours they're going to be in the intensive care unit. I always tell people right off because people tend to think there's something wrong, and it's just so they can have a nurse one-on-one, see how the kidney's doing, how they're doing. They're going to have an IV where they're getting the first doses of the immunosuppressant drugs. But both donor and recipient are up out of bed the next day after surgery, walking around. And for the recipient, you know, it's a major life change, like Pam mentioned too. They're juggling. Hey, I had the whole way how to do dialysis down. Now everything changes. I got to get my blood drawn twice a week. I have to learn about these medicines, when to take them, how to get them. Whereas now they're telling you don't drink. Now we're telling you we want you to drink. Drink, drink, drink. Water. And then food all of a sudden tastes better. You know? Choice. Yeah. And you have more choices. So we're telling people, hey, you know, be active, because you're going to eat more, you're going to start gaining weight. So when people say, what can I do to prepare for transplant? Be active, stay healthy, know your medicines, don't just know the color, know their names, write them down, have a list, and really be proactive with your physician, knowing what's going on with you. I know that there's a time when we all think, gee, the doctor's going to take care of us, but they do that, but I think you can't speak high enough about a person being involved in their own care. So.
Can we go back to one of the financial questions that we were talking about, double insurances and price of medication. What about the donor? Who pays for his share, for his fees?
Very good question. Yes, so the donor surgery is actually considered by most insurance companies as part of the actual transplant. So the recipient's insurance usually covers all the donor workup costs, the surgical costs, and the follow-up care up until they're medically cleared. It doesn't cover them forever, but until they're feeling back to normal. So the answer is donors really don't need to utilize their own health insurance to donate a kidney. But one thing that donors need to be aware of is that they could have some difficulty later in life getting health insurance, or health insurance maybe by having a waiting period or paying higher premiums, or in rare cases even being denied by certain companies. We've run into a couple of those cases.
Yeah, which is not supposed to be happening, so hopefully legally at some point that can be addressed, because to the government they pay more to keep someone on dialysis than to transplant someone. So our government is very pro-transplant, and we were always told that donors, aren't having troubles getting life insurance or health insurance. So it's one of those things where things have come up. So, one of those things to think about.
Let me get her. She had a question.
Oh, it was a question going back to the waiting list.
Mm-hmm.
If you said all the transplant centers in this area are kind of like on the same list, do you have to specifically be on your transplant list to be on the shared donor?
Yes.
Okay.
Yeah, I think I'm not sure about UCSF, but I think Stanford is developing their own paired exchange program. But to be part of the 185 pairs that are in our paired exchange right now, you would need to be on our list.
And they look
Except
I'm on your paired list.
That's right. She's listed. That's right.
Stanford.
Okay, so that's right. She's listed another center, but they don't have their paired exchange program running yet.
They're
just getting it going. So she's entered her. She's not on our list, but she's entered her name and her lab work into our program, so that if a match does become available for her with our center, then
I go off the list at Stanford.
Then she transfers her waiting to, or she changes from Stanford to our hospital in order to do the transplant.
But they're on for two different things. The Stanford list is for donor.
Yes, the Stanford list is for a cadaver kidney, and the paired is separate. But yes, I am on your list for paired.
So you can be on. So it's like two lists.
Well, it's not.
You would be on a regional
She's
one and then a paired
right.
list.
She's officially on the regional list under Stanford, but she has her lab work entered into our CPMC system, so that if a pair does become available, then she'll have her transplant hopefully with our center.
Right, and I actually had to sign something to say that if you find a pair for me, I will willingly leave the Stanford list and come onto your list. So.
But
yeah.
if you consider
exactly.
if you consider the motivation of CPMC or others on that, for paired donations, you need fairly large amounts of data. Maybe not huge, but you need large amounts of data. And if Cal Pacific finds a pair outside of its list, it's in their interest, in order to get a transplant for somebody who is on their list, to take somebody from another list. So that's in everybody's interests, and it's a fair resolution to transfer your time to the Cal Pacific list. coming back to the question of insurance, I guess I just wanted to relate my, I'm sorry, did I, I had an experience about donors applying, as I'm a potential donor, and I've applied for long-term care insurance, which a lot of financial planners tell you you should get. And it's, donating a kidney is not something that puts you in any kind of jeopardy, but I just recently applied for it, and all of the insurers declined to review me while my application, while I was a potential donor. And the answer was, once the organ has been donated, then you'll be reassessed. And I'm told, although we'll learn this when we learn it, that your health will be looked at independently of whether you donated a kidney. But the main reason, they say, is because you're facing the prospect of some kind of significant surgery, even if it's less significant than it was. So that's the kind of issue you do face. And it's not a huge issue for me because I'm more worried about long-term care and the impact on my family when I'm 68 and something badly goes wrong. But it's something you have to pay attention to.
You got a question right here in the front.
Oh, yes. My question is, when you say O blood, now there's O negative and O positive, what I am. So do you have to match an O positive person with an O positive person, or is it just O?
Whether it's positive or negative. So as long as the blood type is O, that whether positive or negative would be compatible with you.
Wow.
Did you guys hear the question in the back? She wanted to know if positive or negative. It doesn't, just as long as
the question was O positive, O negative make a difference? The positive and negative doesn't make a difference in transplantation in any blood type. Somebody had a question over here.
What exactly is the day that you begin accruing time on the waiting list? Is it from the day that you show up and do kind of a pre-evaluation interview? Is it the day after you complete all of your examinations, or exactly when?
It's different for other centers. Some people, I think Stanford might be this way, that they don't list you until you do the test. Our center lists, as soon as everything that Betsy sends me back from outreach, when I get the blood results back, the serologies that are done, the doctor's report, and the social worker that recommend the person for transplant, and then I put them on the list that day. So we're talking about 3 to 4 weeks from the time that you're evaluated will be the time you would go on the list. And then sending out a letter confirming what that actual day is.
Do you see into the future a change in that policy?
They're doing a pilot study. In fact, I just asked about it. I don't.
St. Vincent's is doing.
Yeah, that they're looking at starting the list date when the person starts dialysis. They're just starting to look into it now. I think because there's a lot of people maybe that don't get referred as soon as they could have or should have, and thinking that, gee, that person's lost a lot of wait time in the interim. So I think they're just looking into it now. And then also the fact that, as Dr. Katz-Nelson said, the sooner you get the kidney, the better. How do you transplant the kidney that's going to do the best into someone that's now got to wait all this time, you know? So, I mean, I think UNOS is continually reevaluating, you know, how we allocate organs, but for right now, it's based on, in our region, wait time. The person that's been waiting the longest. Now, keep in mind too, you've been waiting 7 years, you didn't get your tests done, and then here's some people that have been waiting 4 years, they've got all their tests, we're going to pass over you that didn't get your tests done because you're not ready. We're not going to put that person through surgery and everything else when we really don't know, is it safe, you know, is their heart okay, is everything else going okay. So we specifically have meetings that we call top of the list meetings. So a lot of my calling, I'm going to be centered on the people that are going to be getting their kidneys in the next couple years, calling them up if I haven't heard from them. Did you get your test done? Oh yeah, I got that done a year ago. But, you know, I didn't know about it. So when you get a test, like I said, call me up or the coordinator that you have, say when and where you've had it done. And then when you're active on the list, we still want to hear from you. How are you doing? Every time you go in to the hospital for anything, gee, I've had a cold, I've had this, I had a transfusion. Let us know. Because we're only going to see you maybe once every couple years, even though you're on the list. So we might not have the big picture of how you're doing.